want to introduce the Mott, the John M. Mott Lectureship today. This is one of our endowed lectureships that many of which we have in the Department of Surgery and proud to have, that really honors the legacy of an early member of our department who went on to Kaiser to develop the Kaiser program and to solidify the relationship between the Kaiser system and the UC Davis system to develop a rich and diverse training experience for our residents. And this has been one of our signature lectureships over the years. And I will invite Dr. Suring to introduce Dr. Ramamoorthy.
Thank you, everyone, for being here. It gives me great pleasure to host Dr. Sonia Ramamoorthy here at UC Davis. This is the first time she's here at Davis, so that's great. She is very well known in colorectal surgery, one of our premier sort of leaders. She trained at Boston University for med school, did her residency and research fellowship at UCSD, so she's very familiar with the University of California. She did a fellowship at WashU, where I was also many years later. And then she has been at the UC on faculty and for the last 20 years. She is an amazing physician, leader, educator, and innovator. She has started a bunch of new tech things for our society nationally, including the New Tech Committee of FASCRS and the Surgical Leadership Institute because she strongly believes in physician governance and the importance of physicians taking charge of sort of the medical system from just administrators running it. She is the current president of the American Society of Colorectal Surgeons, which is the largest colorectal surgical society in North America. She is the fourth woman president and the first Asian woman president of the society. Welcome, Dr. Ram.
Thank you, Ankit. That was really a very nice introduction, and it's really an honor for me to be here with all of you, friends and colleagues, many people who I've known for a long time. I want to take a quick minute and tell you about how I know Dr. Farmer. My first job out of fellowship was at UCSF, and I was so excited to be there with all these big wigs in surgery, not the least of which is your chair. And I was super excited to meet her and get to know her. These are role models. These were, women in surgery at that time. There was like 5 big leaders in this country, and she was one of them. And I was so excited to meet her. But my partner at the time was like, okay, calm down. No fangirling around Dr. Farmer. She's a busy lady. She's really smart. She means business. Stay away from her and Dr. Asher. Don't go hovering. So from afar, I would be role modeling and learning from her and everything she's done. And she's truly been a mentor and a role model for many of us women leaders in surgery. And you're so very lucky to have her as your chair. That brings me to Ankit, who, yes, I probably was at WashU 100 years before he got here, but he has done an amazing job in colorectal surgery. He's well known nationally. He's so well liked. I got to know him through my former partner, the one that told me to stop fangirling Dr. Farmer, is Mika Varma, and she was the first person to hire Ankit, and she tormented me and continues to torment me for pitching his name to Dr. Farmer as the chief of colorectal, because he's just so well liked and so well known and has a lot to offer. And this is one of our upcoming leaders in colorectal surgery, so pay attention. The last person I want to recognize here is this guy. Where are you? There you are. My former resident. You got to watch out for him. He's smart, he's humble, and he's nice. It's a sickening combination. And I so very hope you're doing well here, Sean. We really miss you at UCSD. I hear good things. All right. Really an honor to give this talk. And I want to talk to you about something that's near and dear to my heart, both as a leader of a colorectal organization and as someone who's been in practice with colorectal surgery for over 20 years. And in that position, I've had the opportunity to watch a change happen in my practice. And that change has been seeing someone who typically walks in the door with colorectal cancer who's 60 to 70 years old to now people walking in their 20s and in their 30s. And it's quite scary when you see that happening. I have kids in their 20s. And so to me, it was an amazing transition. Something very urgent and terrible is going on, and I wanted to try to figure it out, and I wanted to bring attention to it. And really, I've been watching this over the last 5 years, but it was, there's just like a straw that breaks the camel's back. And so there was a woman that walked into my clinic, in like 42 years old, right? And I see this every week, but she comes in terrified, right? She just had a colonoscopy for rectal bleeding that she had been having, and she had a colorectal cancer there, right, in her descending colon. And I was trying to reassure her. She was a mom. She had kids starting from 16 all the way down to 4 kids. Her husband was in there with her. At that point, we didn't have any of her staging information. And so I was talking to her, it's going to be okay. We're going to take good care of you. Don't worry. This is how we manage colorectal cancer. You're going to do fine. No family history, no exposures, nothing that we could kind of identify what was going on with her. And later that day, I'm talking to her referring doc, her primary care, and we're on the phone because I had just gotten her staging scans. I'm like, oh, they just came up. Let me look at it. Mets to her liver, Mets to her lung, Mets to her bones. It was awful. It's awful. And we're seeing that every day in colorectal surgery. So we all have to change this. And whether you're a trauma surgeon or a surgical oncologist or breast, we have to be attuned to what's going on in the field so we can identify these things in the community we treat, in our family members, and in the profession that we're in. All right. So the learning points we're going to walk away with today are understanding the scope of the problem, clinical presentation of these patients, it's a little bit different. How early onset colorectal cancer is different, or is it different from what we call average onset colorectal cancer? What could possibly be the etiology of this, and what can we do about it? This is an advocacy group, Fight for Colorectal Cancer. There's 2 kind of big ones, Colon Cancer Alliance and Fight for Colorectal Cancer, and we align with them as a society. But they did this in 2023. They got out in Washington, D.C. in front of the monument and put all these flags out there for all their loved ones who had passed away, and trying to bring attention nationally to what's going on. Okay, I'm going to put my old lady glasses on. I apologize for that. All right. So what is early onset colorectal cancer? Well, for those of us in the field, it's anybody diagnosed under the age of 50, right? And when I initially started talking about this, we were saying that the incidence was about 1 in 10. Okay, so I started giving this talk about 5-6 years ago. And now it's 1 in 5 of cases that we're seeing are under 50. That's a lot. Right? It's the top 3rd most prevalent cancer worldwide. So it's not just affecting us here in the United States, it's affecting us worldwide. And it's the 2nd most lethal, right? We have access to good health care, most of us, but that's not true everywhere. But look at this. This is what's happening across the globe. And so these darker colors represent industrialized countries, right? So we think lifestyle is playing a role in this. This is happening in Europe, happening in Australia. We partner a lot with our colorectal colleagues, and very high rates in Asia as well. So it's a global problem. Early onset colorectal cancer has nearly doubled since the 1990s. It'll be the leading cause of cancer death in patients 20 to 49 years old by 2030. That's an extremely big change in our cancer numbers. 70% are sporadic, so they don't have a family history. They're not part of any hereditary syndrome. And what's driving a lot of this is rectal cancer, right? So if we think about exposures and stuff, why is it getting all the way to the very end there and causing a problem? What do we think about that? So here's some information. Looking at early onset, it is more distal. It's happening in the descending colon and the rectum. The rates of the proximal colon cancers, like right colon cancers, are staying about the same. Here's the age group incidence. It's going up. You can see that increasing significantly in this age group. This is your age group. I'm not trying to scare you, but I am trying to get you to think about these things as you practice, as you get out there, and as you live your own life, and you have the ability as leaders to influence your colleagues and influence your cohort. And you can see, I don't know if any of you remember the Couric effect, but Katie Couric got out there about 20 years ago and was talking to people as her husband had died from rectal cancer about getting a screening colonoscopy, and videotaped herself getting a colonoscopy. And that had an amazing effect. You had a lot of people just by doing that was our social media back then. Doing that small gesture really changed people's attitude about colonoscopy, and more people got screened. And you can see that impact, that Couric effect, dropped the rates. People were getting screened when they needed to. And so if you're over 50, you're pretty much in luck. You're starting to, if you're getting your colonoscopies, you're going to be okay, because the at-risk group is your age group. Now, we're recognizing that there is a birth cohort that's at risk here. And this is when it's starting. It's starting in the late 60s, early 70s, and it's taking off from there. So what happened then? Did a nuclear bomb go off? What happened? Any ideas? Anybody? I hear whispering. Just throw it out there. You're UC Davis. Come on. What? Anything? All right. Fast food? Maybe. I know Dwight would be worried about this right now. Something is going on. Something scary is going on. And I'm not sure we have the answer, but we have some ideas. All right. When we look at this birth cohort, we're recognizing this is true globally as well. So there's some exposure risk, and we know it's happening in industrialized countries, Europe, Australia, United States, Asian countries. So there's some commonalities in the way we live our lives. And while there are modifiable risk factors, there are non-modifiable risk factors. And the non-modifiable risk factors for colorectal cancer have not changed, right? Being old. As you get older, you have a higher risk of developing polyps and things in your colon. So you're not going to be able to change that. Personal history, if you have inflammatory bowel disease, or if you have a family history, if you have Lynch syndrome or hereditary syndrome, can't change that either. That's a non-modifiable risk. And we talked about family history. So these are the modifiable risks. Use of alcohol and tobacco, which I think we've always known bad for you in alcohol in high quantities, and we're finding that smaller and smaller quantities are even at what we thought was one glass would be okay every day is probably not okay. And of course, tobacco, I think we've learned a lot about through our lung cancer research. But lack of physical exercise and your diet has always something that we sort of say as colorectal surgeons and oncologists and primary care doctors to people without really understanding what it is. What is it about exercise? I used to think it was just that you gained weight. And so that's why you wanted people to exercise, because clearly being overweight was a risk for many different lifestyle cancers. But there's more to it than that. We're going to learn about that. So it's these modifiable risk factors that we think are potentially the etiology behind this early onset colorectal cancer. So let's talk about them. This Cookie Monster. Okay. So what's in the Western diet? Well, first of all, we eat a lot, large quantities. If you ever go to France, you're like, where's the food? Right? They serve smaller amounts in other countries. We often prepackage our foods. Everybody's living busy lives. In my lifetime, my mom stayed at home, but she still loved the fact that we could drive through this like restaurant with big arches, and you could just go to a window and order dinner for everybody. So we would have Happy Meals, Kentucky Fried Chicken. I know I'm Indian. You didn't think that was, yeah, but we did. We went for all of that stuff. Refined grains, red and processed meats. Right, all the sandwich meats, the processed meats, the stuff we've done to our meat. High sugar content foods, high dairy animal proteins, low in fruits and vegetables. Low fruits and vegetables in our country, even though we have access to that, and low in plant-based proteins. Somehow we've gotten away from that. So that has been a shift in our culture and our dietary habits. So with all of these increasing incidents, what is the main issue here? When we look at these risk factors and we look at the diet, plenty of data out there to tell us. We know that westernized diets increase our risk of lifestyle cancers, breast, prostate, colorectal, you can name them, probably renal, esophageal, pancreatic. We're finding more and more are implicated in the way we live our lives. Red and processed meat, plenty of data, not just locally where we're doing it, but globally, increasing inflammation in our bodies, and that exposes us early on when we're having that stuff as babies and small kids, and think about that 20 years, right? So why wouldn't you get something when you're 20 and 30 years old? If all of this process is starting when you're in your 2, 3, 4, 5 years old, you've had that 20-year timeline, right? Obesity, a huge epidemic in this country. Stress, they're finding antibiotics now. We used to treat a lot of young kids. I used to put my kid on all kinds of stuff for his ear infections and things like that. That stuff was dangerous. We didn't know any better, but they were risk factors. They changed the gut microbiome, and we think the gut microbiome could be at the end of this pathway causing some of these problems. The synthetic dyes, all the different things that we're putting in our food, the high fructose corn syrup, right? And what do all these things do? They can modulate inflammation. They can modulate the microbiome. They cause chronic inflammation in our gut that then leads to dysbiosis. And we know, plenty of data out there, we know that dysbiosis over time, leaky gut causes problem, the chronic inflammation, and we know the chronic inflammation a cancer pathway. So all of these things are driving changes in our gut that are leading to colorectal cancer. So multiple large population studies showing an association between red processed meat consumption and the risk of colorectal, right? And it increased more on the left, on the rectal side, than on the right side, interestingly. The mechanisms are all the different byproducts of these meats and some of the things that are in them. They lead to insulin resistance, obesity, mutagens, and then eventually, as we said, chronic inflammation. So going back to what happened, right? We saw that birth cohort happening starting around 1970. Here it is. What was going on at that time? Well, look when obesity hit us, right? It started tracking around the same time. And look at our activity level. We started changing what we were doing. We used to do a lot of PE in school starting off, and there's still requirements for that. But the amount of physical education that students are getting in school, the timing has decreased, right? So it used to be a lot of time dedicated in school to that. You still have to have, kids still have to have physical education, but the amount of time goes down and it doesn't continue, right? So now my daughter is a sophomore in high school and she sort of can electively choose to do this and that physical education. So we've really changed our lifestyles. It's affecting our young people and it's having a negative effect in their health. So here we go. Light activity increased, but moderate and strenuous activity, and those are the things that we think are actually beneficial in terms of cancer prevention, has gone down, and our sedentary lifestyle has increased. So here's the 70s, right? And what we changed in the 60s and 70s was a lot. We started having larger portions. We started adding a lot more sugar into the foods because we wanted people coming back and getting those big gulps, right? The big gulp came out in the 70s. This is what I used to have when I got home from school. I'm a setup for something bad. I get my colonoscopies on time, but Twinkies and Ho-Hos, right? Oh my God, we used to get those all the time. Such bad stuff. All that came out in the late 60s. The Happy Meal was born in the 70s. So all this good stuff started happening around the same time that we start seeing obesity, we start seeing sedentary lifestyles happen, and we start to see that shift in our early onset colorectal cancer. At the same time in the 70s, we started seeing genetically modified crops. That started taking off in the mid 70s and was in full effect by the late 70s. And high fructose corn syrup. These are just to name a few things, right? A few triggers that we all know. Started being added to things that, why would salad dressing need to have high fructose corn syrup in it? Started being added in the 70s to lots of different foods that we eat, right? And we started like downtrending when we figured out it wasn't good for you in the early 2000s. A lot of temporal relationships. All right, how about that's enough about food. Now that I've ruined your appetite. That's enough about food. Let's talk about exercise. I know you all exercise. Well, the World Health Organization ranked physical inactivity as the 4th leading cause of global mortality. It leads to 6% of deaths globally And it, again, is related to our lifestyle cancers, breast, colon, prostate, and others, as well as many other diseases out there. When you look at multiple studies that are out there, this is a pooled analysis that looked at the correlation, and they looked at it over several different decades. There's a strong correlation between physical activity and lower risk of our lifestyle cancers. A strong correlation. It can be lower for some of these other cancers, but very strong for colorectal and breast, right? And then they correlated to sort of back check what they're looking at, sedentary, sitting time. So if exercise is a strong correlate with cancer prevention, what does a sedentary lifestyle do? And that has an increased risk, not surprising. Here we look at the same analysis and look at the hazards ratio, the risk associated with high versus low physical activity. And again, you can see for these lifestyle cancers, physical activity makes a big difference in cancer prevention. I give other talks where we look at physical activity, not just cancer prevention, but once you get the diagnosis. Those folks that exercise during diagnosis actually can shift their survival curve for themselves as much as another chemo agent would do. And actually exercising during chemo treatment reduces the risk of things like polyneuropathy and some of the side effects we get from chemo agents. So hugely important if you can get your patients to keep exercising, and even after cancer survival, the prevention there is huge. So there's a huge benefit to that. And it's not just about what you eat or obesity, it's about the effect that that exercise is having in your body. I'll talk a little bit about that. All right, sedentary behaviors. This is a great study that was published in the Journal of the National Cancer Institute. It looked at a nursing cohort between 1991 and 2011. It was a prospective study, 89,000 nurses between the ages of 25 and 42. And they excluded anybody that they thought might be at high risk for colorectal cancer, someone with a family history in a first-degree relative, or anybody with IBD. And they looked at sedentary or TV watching time, right? And you can see here the number of cases of early onset for those people with the number of cases of colorectal cancer were higher in those people with sedentary lifestyles versus those who were more active. When they looked at the group of people that had colorectal cancer and compared them with BMI, so they wanted to do a subgroup analysis and say, well, how much does BMI impact someone with an early onset colorectal cancer? They found that someone with a lower BMI actually had a relative risk that was lower than someone that had a higher BMI. So actually, if you have a sedentary lifestyle and you have a high BMI, you're super higher risk, right? And more physical activity led to lower risk versus lower physical activity. And the same with smoking. So what does physical activity do for us? It has the benefit of the things that we know about, right? Helps us with our mental health. We improve our cardiac output. We improve our oxygen transportation. But we also elaborate a lot of biokines and anti-inflammatory cytokines and things that benefit our body and counteract the effects of many of the mutagens that are living in our body at the same time. So when we're exercising, our muscles are actually doing something that help us fight off cancer. We're always developing mutations in our body. We're always developing dysbiosis in our body. And there's something that's actively being done with active exercise that helps prevent that. So how do we know that? How do we know that we're seeing a different species in our gut when we exercise? How do we know that we're enhancing our intestinal barrier when we're exercising? There's a couple studies out there that show some really important changes, and I'll show you that. We know that physical activity changes the composition of the microbiome, and I'm going to show you a little bit about a study here. So it was kind of a fun study, but it was an international study of rugby players, and they did two groups, right? Controlled for age, gender, and diet. So it's a small study, but it got a lot of attention. It was published in Gut, and that's a really big journal. The average age of the person was 29, these rugby players. The control group had a BMI of less than 25, and then there was another control group that had a larger BMI, right? So the difference between these two is their physical activity, the rugby players versus their age-matched person who had a low BMI, and then their age-matched person that had a higher BMI. And when they looked at the biodiversity in their gut, right, their good microbiome, you can see that the athletes, and these are different ways in which you might measure the microbiome for someone, you can see that the athletes clearly had more biodiversity, and biodiversity is associated with a good microbiome, which is associated with less dysbiosis, less inflammation, and less risk of colorectal cancer. So you can see here that exercise actually makes a big difference. Now, having a higher BMI puts you at risk, but having a lot of physical activity in your life makes a big difference in your gut. Now, who it gets, right? You're working out, you're running. How is that affecting your gut? But it does. And so we're a finely tuned machine, clearly integrated with everything we do, and exercise does affect your gut. So the link between cancer and microbiome is very clear. There's commensal bacteria that we need that are good, that produces the food for our colonocytes, and that's what keeps our gut barrier healthy. When we are increasing inflammation, we increase permeability, we increase a lot of local sepsis in our gut, a lot of inflammation, a lot of insulin resistance, and this is all promoted by high-fat diets, high-sugar diets, large quantities of food, sedentary lifestyle, and believe it or not, antibiotic use, right? And this allows this dysbiosis to occur in our gut, and then all those things lead to chronic inflammation. If all of that starts in the 70s when you're born, then you can imagine by the time you're in 1990, 1999, you're in your 20s and 30s, we start to see these polyps, we start to see colorectal cancers. So there is a question out there: is early onset colorectal cancer genetically different? When we start looking at the genome and we start doing these sequencing, is the pathway different than what we typically know, right? We have the chromosomal instability, we have methylation pathways, we have microsatellite instability pathways. So are all these the same pathways that are happening in early onset colorectal? Or this is a great study that came out of Memorial Sloan Kettering that looked at their cohort of patients. So they had 959 early onset colorectal cancer versus 687 average onset. And in their early onset, they even broke it down further to look at a group that is between the ages of 14 and 35. Yes, 14. I've operated on a 14-year-old with colorectal cancer. And then another group, which is 30 and 49, and then a group over 50. Right? And they looked at any number of things that could be driving their disease that's different than what's happening in the average onset. And they found there was no difference in the gene or in the pathway. There was no statistical difference in the tumor mutation burden, the fraction of genome alteration, or loss of heterozygosity. So they're following the same paths. It's just accelerated, and it's happening at a younger age. That's what we know now. There's a lot of research and effort going into this, and so we'll maybe learn more. I would tell you my observation, probably your colleagues here would tell you the same observation, is when we're seeing these patients, we're often seeing a poorly differentiated cancer. We're often seeing a mucinous cancer, and those are really hard to treat. We're not quite sure why they're triggering these worser prognosis cancers yet. But genetically, at least in this is the biggest study so far, is showing there's not a big difference. All right, how about clinical presentation? This is where I think we all need to pay attention, because this is where we're dropping the ball on these patients. Early onset colorectal cancer patients. This was published by a colleague of mine at UCSD, Samir Gupta's group. So he found that 82% were initially misdiagnosed. So they're coming in to see their doctor. And this 40-year-old woman that walked into my office, she's health literate. She is not living on the outskirts with marginalized care. She's got great health insurance, and she still didn't know any better. And she went to her primary care, and she had been complaining. She saw me in September. This business for her started in December. She saw her primary care in January, and just kept going back, and then had to get set up for a colonoscopy. That didn't happen. Life happened. That didn't happen until June. There's huge waits for colonoscopies out there, and eventually sees me in September. That's almost 8-9 months since her initial presentation. And who knows what her initial presentation would have been like if we caught her in January. Maybe no difference, but maybe it wouldn't have gone to her bone and her liver and her lung. 73% are diagnosed at a late stage. This is why. My lady exactly is the classic reason. 50% of the patients felt their symptoms were ignored. They're being told, I mean, when they're in their 20s and 30s, you probably have a fissure, you probably have hemorrhoids, you probably ate something. 67% of the early onset patients saw at least 2 providers before their diagnosis happened. Shocking. And 60% plus had no family history. This is the current guidelines from the U.S. Preventative Task Force. We dropped the age from 50 to 45, but many of our primary care doctors don't know that. In fact, if you go to the ACP website, they'll still list 50 as the screening. So we have to get the word out there to our frontline providers. Signs and symptoms. So the primary symptom that these patients are complaining of is rectal bleeding. Recall that rectal cancers are driving a lot of these numbers. So it's not surprising they're having rectal bleeding. Abdominal pain and altered bowel habits. And they're kind of living with this for months and months and months, right? And they're seeing people, and people are kind of giving them Prep H and different things and start a fiber diet. But you can see from the time that they're initially, and this is looking, across the country, when they're first complaining of symptoms to the time they actually get a diagnosis, on average, it's about a 4 to 6 month delay. That's too long, right? Cancer spreads in that time period. That's too long. And if these are more aggressive forms, we're not sure, but if they really are poorly differentiated, signet cell, mucinous cell, you better believe it's going to spread in 4 to 6 months. All right, management considerations. I'm going to finish up here. Right on target, my daughter's calling me. Okay, so management considerations. Is early onset colorectal cancer to be managed differently than average onset? For sure, for sure. Your colorectal surgeons would tell you the same thing. These are people in their 20s and 30s. These are us. This is you. What would you be concerned about? Can I have kids? So they ask, what's going to happen if I get radiation to my pelvis? Well, guess what? You can't have kids. So you need a fertility specialist there before we start treatment to go in and harvest those eggs, to talk to them about, sperm and if they're going to be able to have children. And maybe they're going to need a hysterectomy. But somebody has to have those conversations because this is really weighing on people's minds. It's weighing on their spouse's minds. It's a big deal. Many of our patients, we've seen, I would say in my lifetime, I've probably operated on 5 women who are pregnant with colorectal cancer. And of course, pregnant women get ignored the most, right? Their symptoms are so vague and likely attributable to their pregnancy. Constipation, abdominal pain, all those things. When something gets big enough, and typically 3 of those 5 patients I operated on, it was an ovarian mass on the ultrasound they found when they were ultrasounding the baby. And that's, obviously spread of the disease. For colorectal cancer, especially rectal cancer that we're seeing in the young, some of the side effects of the disease we're treating when we're doing the operation is sexual and urinary dysfunction. So when we get in there, those nerves, for whatever reason, are wrapped around the rectum, and it can have a significant effect for young men and women. It causes a lot of psychological issue. We can cure them of their cancer, but they're left very scarred by the side effect of the operation itself or the treatments. The long-term impact. So let's say, hopefully, we get to cure these people and they're going to live a long time. If they're 30 when they have colorectal cancer, we have to think about the implications of the treatments we're giving them. So there's a lot of research being done in colorectal about, hey, can we get away from radiation therapy and treat people with chemotherapy? Not that it's a whole lot better. You get neuropathies that will last you forever, but maybe you won't have to have radiation to your pelvis. Because we know that down the line, radiation 20 years later can cause another cancer in the area, right? So we have to be sort of attentive to our younger population and think about those things. And as more data sort of supports that we can treat some of our colorectal cancers and rectal cancers with chemo alone, that might be the approach we're taking for our younger folks. I was told a story by one of my colleagues at UVA, Charlie Friel, and he was saying he was so happy that he treated this young guy, 35, and he does a kayak business, right? So he runs a kayak and he takes people on tours and stuff, gets in the water, and he cured him of his colorectal cancer. And he was really happy about it. And he saw him probably 5 years later, and was asking him how it's going. He said the guy looked like hell. And he couldn't figure it out. He'd been cured of his, he was one of the lucky ones. He got cured of his disease. And he said, I have these neuropathies in my fingers and toes now. I can't kayak. I can't go in the water. I spent my whole life in the water. That was my whole career. He's like, I'm not doing what I love doing anymore. So yes, he has his life, but there's a lot of consideration that goes into how this affects younger people psychologically and the mental health impact on the patient and the family. In my particular patient's case, I don't know that she's going to live another year or two, but think about those 4 little kids, right? All right, so what can we do about it? We have to educate our frontline providers, our PCPs. Sometimes these folks are showing up in the emergency room, especially if they don't have access to good health care. They're going to show up to the emergency room with these symptoms. Our family medicine docs, our gynecologists, all these people that see people on the front lines, they need to be educated. We need to educate them that they need to treat the symptoms. If someone's having rectal bleeding, abdominal pain, okay, probably it is just a hemorrhoid. Probably it is nothing, food poisoning, whatever. It'll get better. But just recheck and make sure that those symptoms have gone away. And if they haven't, then refer them. Get them a scope, send them to colorectal, wherever you got to send them, but don't drop the ball there because it could be something more. We need to educate patients about the disease to know their symptoms. If they're having symptoms and things are not getting better, they need to get in. They need to advocate for themselves, especially in this day and age. We need to collaborate with industry, and our society is working with that along with AGA, the Gastrointestinal Society, to try to convince our industry sponsors that there are people that don't have great access to colonoscopies, may not have many. What can we do to get a fit test, and what can we do to get a Cologuard to them? How can we make it more affordable? How can we make it more accessible? Is there ever going to be a direct-to-consumer way we can test these things? Because that might be something that actually helps our problem, or at least gets people triaged properly. And then we need specialized centers for early onset colorectal cancer. So that could be a program within a colorectal group or a multidisciplinary group with surg-onc and medical oncology and others within a cancer center, because these people need specialized care. It's not the same as average onset colorectal. And it probably falls into a very similar bucket as patients that have breast cancer who are very young and some of the side effects that happen in that age group. And as we see some of these other lifestyle cancers happening younger and younger, we're going to need to develop this arm in our cancer centers to address the needs of our younger populations. All right, so the takeaways. Colorectal cancer is on the rise, in particular in left-sided lesions and rectal cancers. Public education is critical to avoid the delays in our presentation and delivery of care. Hereditary colon cancer only explains a small percentage of early onset colorectal, and the pathologic mechanisms are still working out. But right now what we're finding is it's very similar to average onset, just an accelerated pathway. We think that lifestyle-related risk factors remain the significant cause of the disease, right? The temporal relationship is there. The relationship with industrialized countries across the world is there. So we all have an opportunity to change the way we live our lives, those of our loved ones, those of the people who we treat every day, talking to them about these issues, because it's likely through a mechanism of dysbiosis and chronic inflammation in the gut. And of course, encouraging a healthy lifestyle for everything. Thank you so much.
Well, Dr. Ramamoorthy, Sonia, I just want to thank you for coming. It's so great to see you and great to have you here. Before we do our formal thank yous, we have some time for some questions, and I suspect there are people who have questions in this room because this is the age group right here, as you actually said. So let's talk about it. So let's start with one of our colorectal faculty.
Good morning. We'll meet a little later. Wonderful talk. Thank you so much. My question to you is, you get referred a patient to your office for hemorrhoidal bleeding. You do an anoscopy and you find hemorrhoids. How young would you reflexively scope this patient?
So we typically start treating them. We would do what we're asking our patients. So we treat them. We'll try to see, can we solve your hemorrhoid problem? We bring them back and ask them if their symptoms are better, right? So it's not necessarily an automatic colonoscopy, but we do talk to them. I always talk to them about it from the get-go, right? I'll be like, hey, it's rectal bleeding, but and I'm going to try to treat this, and I'm going to give you some topicals and see if things get better. You're going to start taking a high fiber diet, and I'm going to bring you back 6 to 8 weeks, and if things are not better, then might refer you for a colonoscopy, just to make sure, right?
Is there an age limit that you get more concerned than others, or I would say when is your concern high enough where you would scope them or refer them for colonoscopy immediately?
Symptoms. Yeah, so someone with just plain old rectal bleeding and nothing else, I'm probably gonna just, let's say, let's treat your hemorrhoids, or especially if I see something on anoscopy that's obvious. Someone who I don't see anything on anoscopy, and they're giving me a history of rectal bleeding, or they're telling me they not only have rectal bleeding, but now their bowels have changed, their belly's funny, all of that other stuff. Like, maybe we're going to do a colonoscopy sooner rather than later. And, thankfully, colorectal, I don't know if you guys do colonoscopies, but we do at UCSD. We can get them in sooner sometimes than our GI docs can, if we're that concerned. And it also allows us an opportunity to treat the hemorrhoids if they're not responding to conservative measures. So it's two-term.
Maybe that'll be our answer to 48X. Turn it into a outpatient colonoscopy center for colorectal.
We're ready.
Yeah, that's what we're doing with our new.
Absolutely, to hell with them. I mean, did I just? Okay, it's only 8:00. All right, we're gonna pop over here, Dr. Ekreb.
Thank you. Thank you so much for your talk. I'm Rachel Ekreb. I'm one of the clinical fours, and fingers crossed, hopefully a future colorectal surgeon. So my question, you've alluded to a number of times in your talk, sort of the social determinants of health, and if even well-resourced young people are having delays in diagnosis, what are the implications for those with less resources? I was also wondering, what I'm wondering is, with labeling all of this as like lifestyle, does that take the burden away from all the factors that create our food environment, industry, companies? I mean, we've seen how go. Thank you, Dr. Z. Is there a role for surgeons to advocate to change that landscape so that we're really addressing those root causes of people's access to better food? Thanks.
I love that question. You're in such a unique place here at Davis. Nobody has what you have. You have access to some of the best kind of food and agriculture people in the research world, nutrition world, compared to anywhere else in the country. I've looked into this. And you could do so much work with the groups here in this particular area. And specifically looking at how what the etiology is and how you change that. Right, because we've done this to ourselves, but we can also change it going forward. And you're right, the people that have poor access to healthcare, God knows what's going on out there. We see that at UCSD. We have a huge Hispanic population, which is a fast-growing group for early onset, as well as Black Americans. And so you worry a lot about what's going on because they often don't get in our hands, and we see these really awful, very, very advanced cases. And so I think we have to, find a way to reach those populations just to provide the education. And I'll give you an example. In a small way of what our society does is each city we go to for our annual scientific meeting, we wanted to give back to the community. So the idea came, let's invite kids that are in, schools that are, in socioeconomic disadvantaged areas. And we need to get more of those folks into medicine. So let's bring them in on the first or second day of our annual scientific meeting. We walk them through our super fun exhibition hall. They get behind a robot. They get to play around with the scopes and different toys and things. But then someone had the brilliant idea from our DEI committee that let's get their parents in. Their parents are bringing them anyway. They're high school students. Let's get them in and talk to their families about healthy lifestyle, about screening colonoscopies, about symptoms. And so while the kids are getting kind of shepherded around the exhibition hall and having a great time, we're actually talking to their parents about all these things. And so in some small way, will have an impact. I think you're in a great place here at Davis. You have such opportunity here, right? You have these populations you can take care of, much like UCSD. You have an incredible nutrition department that's publishing a lot of data in this area. So there's tremendous opportunity to impact this area. Well, I just want to leave you with two other things. So as surgeons, there are some other fields you can get into that'll help educate you. So there's a certification in something called culinary medicine, right? That teaches you all about food and food that can cause inflammation, gluten intolerance. Everybody thinks they're gluten intolerant in LA, but all of those things that actually, whether they do or they don't, have an impact. And it provides a little science behind some of the counseling you're going to do to patients. So something to think about.
Let's give our residents, Tammy.
Sammy, resident, quick question. Have you had a lot of trouble with insurance companies authorizing the younger patients getting colonoscopies, or when you're asking for it, they're getting what they need?
So it's all about how you document it, right? So if you are documenting that you don't have a clear-cut cause for their symptoms and that this is no longer screening, it's surveillance, there's something triggering the need for the colonoscopy, I've not had an issue with that.
Dr. Miller.
I'm one of the colorectal surgeons as well.
Hey.
Excellent talk. I'm also fangirling you from a distance. I think for me, the most heartbreaking is to see a 20-year-old or a 30-year-old with metastatic disease who's going to die, and their care has been delayed so much. And the problem that I also see is that people think that they're young and so their body can tolerate, more advanced chemo. And I just find like we're not like nervous. And two questions is, is there something we can do? Like the 20 to 30-year-old group there's like a 90% increase. Is there a way we can spread some kind of like high risk awareness for this group? Where, I know 45 seems to be very young, but potentially, creating an algorithm where we have a high risk 20 to 30 because I feel like the PCPs and the people who refer us I don't feel like they're getting it, the urgency of this. And I don't know what, is there something else we can do to kind of target this group as a society?
So I'm going to recruit you because we're working on that. We're trying to, we're kind of a small society. You don't have a ton of resources, but we recently reached out at kind of a meeting for societies, presidents, and I reached out to the AGA and to ACP and family medicine to sit down kind of at a round table with them and say, what can we do? Because we can influence, we're going to talk about leadership with the residents later. Influence is a really powerful skill. And so sitting down and talking to them and figuring out what we can do together. Can somebody like you do a webinar or give a talk at their annual meeting and bring awareness to it? Asking this group, what's the best way for us to reach you? If we had to get this message to you, what would be the best way? Or if you could deliver this message to your cohort, your counterparts out there in the community, how would we do that? We can do those things. The society can do those things. And as an institution, we can do those things for our community for sure.
One last comment related to this, and then I want to invite Dr. Adams to the microphone. But two things. One of the things that I think is unique about Davis is our access to the Capitol, and we have talked before about, and we have a group of residents who are involved in public policy and advocacy, and I think just trying to accelerate this, and this is a great example of a space where we can have an impact and leverage the fact that we're here doing it. The other thing, one of the observations I made, as you did too when I came to Davis, was this amazing ecosystem around food and nutrition. And so our first sort of research emphasis was on surgical bioengineering and device development, right? We're all surgeons. But the second one was really to develop a center for metabolic health and the microbiome, and recruited Sean Adams, one of our former Davis, involved in the agriculture world here, but a nutrition expert, and leads the research arm of our Center for Metabolic Science. So, Sean.
It's a lot of pressure. So,
thank you for what you do.
You can imagine how happy I was to see all of these things today. Let me challenge it a little bit, though. I know the food thing is a big deal, the high fructose corn syrup, and there's a lot of mythology around that, by the way. We could talk about that someday. Yeah. So a lot of those things are shared with colorectal cancer risk, even in older and so on and so forth. So I'm not discounting nutrition, which I hope I don't. Yeah. Also, the physical activity part as well is the big gorilla in the room. And by the way, what's interesting is the bacterial metabolites, or what they do biochemically, changes depending on your fitness level, which is really interesting. And again, a bottle of wine. But what struck me from
Or non-alcoholic beer.
or non-alcoholic beer,
Or just a little bit of wine.
whatever. There's polyphenols in red wine, by the way. Anyway. Oh. Is that Dr. Z? I'll remember that. No, but what struck me from your talk especially was the worldwide map. So it made me start to, I'm going to challenge you a little bit. It made me start to think we could talk about westernized diet. We could talk about a lot of things. But it's kind of odd that there's this worldwide rise when there's not been the same worldwide rise in these other risk factors. Is it possible there's something, a cryptovirus, there's something GI tract microbe shifts that we're not really thinking about because we're so focused on these other things? I have no idea.
There's another map that overlaps with that.
Yeah, no, I think that's actually, there's probably not one silver bullet, right? It's not going to be, it's just your diet, or it's probably all these combinations, but they're manifesting themselves in our younger people. Could there be some work in the virome? Sure. Why wouldn't we study that, better understand that?
Is that still a thing in the cancer world? I don't know that maybe viruses sometimes.
Related cancers, right? We know that, but we've not actively studied it, I think, in colorectal, at least enough to say that it's not a factor in all of this. When we look at these countries, I remember I was in India giving a talk recently, and I was surprised at how their diets are. They used to be tea drinkers. They're now all coffee drinkers. And with coffee drinkers comes coffee mate and all the vanillas, and so they have the lowest rate of colorectal cancer right now, right? There's a lot of anti-inflammatory stuff in their food, spices and things. But I wonder if we watch them over the next 10 to 30 years as they have Pizza Huts there, and they're young people, and the socioeconomic status. They have a huge middle class now that's building with all the outsourcing things. Whether the dietary effort, they're eating more meat now than they used to. It used to be kind of you're Hindu and you don't have cows, but that's all changing, right? And so it'd be really interesting to watch what happens in India. That's one that's gone from developing to industrialized with diet and stuff.
And without a doubt, that obesity map overlaps with that colorectal map. So I just want to thank you again. Officially, we have a little token of appreciation for you coming with us. It is safe to go through security, just so you know. Glad to have you.